Okay. Hello, good evening. Thank you so much for joining us on what is a pretty rainy Thursday evening here in North Yorkshire for Med6 respiratory session. I'm Dr. Aaron, and with me I've got...
Hi everyone, I'm Dr. Shantae.
And together over the next hour or so, we'll be taking you through a couple of cases, but we'll give people a couple of minutes to join. As I know, people are busy and people... Yeah, so we'll start, say 5 past. Yeah, that's really cool actually, going on to ITU as your first one.
Yeah, it wasn't as supernumerary as I thought it would be.
Oh, okay.
I know. So I think my first weekend I was on-call long days, and at my trust, it's pretty much kind of like the SHO bleep and the reg
Yeah.
bleep. You're part of like the crash team, so you go to like all the crash calls, and it was very like long days. It was like 8 till 6, and then
Wow.
I think it's been like throughout the whole 2 years. Well, maybe not F2, but it's been like my busiest job. But it's good though; they get you involved in like lines and central lines,
Wow.
and
Yeah.
ultrasounds, and so yeah.
I've got 1 month in ITU next year, and I don't know, there's just something about arterial lines that kind of gives me the creeps. It's weird.
I always enjoyed like doing ABGs over cannulas, so I don't know, I just found them really fun.
Yeah, I mean, I can never. I either ABGs for me either go straight in. I'm like, yep, cool, I'm in the artery, or I'm there going, really sorry, I need to. I know what it is, but yeah, yeah.
That's good that you get a
looking.
month there next year, though.
Yes, so I get a month in ITU and then 3 months on a medical education job. So it's this for 3 months, but in real life.
Yeah.
So yeah. Otherwise, I would have gotten a full rotation in ITU, but I don't know. Like I say, the environment kind of gives me the creeps. So
I feel like even a month though will benefit like you so much, and you'll learn so much as well.
I remember I was telling an ITU ST8 about how I'm only getting a month, and she looked so offended that I was happy that I was only there for a month. She was like, "Oh my god, but don't you want to do a full rotation?" I was like, "No,
Yeah.
not sorry, but no, just."
I think a month's good because it can be really draining. I think I remember like a 6-week period when there were a lot of like super critically ill patients and not many good outcomes. So it was very like draining and like emotionally taxing. So I think a month is sort of like a good medium to kind of like get that exposure, but then like go away as well.
Step away. It's like, cool, I'm done. Thank you for that.
Yeah.
Yeah, I feel that though with vascular. Some of our outcomes aren't very good as well. So I'm looking forward to going back to medicine and infectious disease and acute medicine. Yeah. Sick. Well, should we get started? Yeah. So the session will be recorded just for anybody who wants to watch and go through the slides with us later. Yeah. Okay. So this is the agenda. I've got 10 MLA style multiple choice questions for you. And these 10 questions, I've looked at the MLA content map for respiratory and picked 10 conditions and presentations from there. So it's all directly. So I'm looking at things that might be tested on your exam. In terms of interaction then, if we're going to put up a poll for each question. And then if people could answer, and afterwards I'll go through what exactly I was trying to lead you down, and if any considerations I might have when I'm seeing these patients on the wards. Does that sound good? Okay. So I just thought I would go through my personal experience of how I kind of go through MLA questions. From what I remember, the MLA question stems themselves tend to be quite thick, so it's very easy to just read it and kind of get the wrong idea sometimes. So what I used to do on the first reading is I always used to think, what's the presentation, or what's the issue that people are actually testing? And once I've identified, okay, this sounds like a pneumothorax, or this sounds like lung cancer, and then reread it again and think about what thing or what knowledge fact is the question testing of me, because when you design a question, that there has to be a right answer, and oftentimes the clues and the information that you'll need will be in there, but it just helps when I was feeling a bit lost sometimes. Alrighty. Okay, so first question. So got a 67-year-old male who's a care home resident, presents to the acute medicine unit with a history of 2 weeks of feeling a bit ill, so feeling not quite himself, cough, and a fever. During the consultation, when you ask him where he is, do you know where you are? He tells you, yeah, I'm at home. And that he keeps wanting to leave the bed and go upstairs to his bedroom. On examination, he's got a fever and he's clearly confused. I've got the A2E assessment there, and he's already had bloods on admission, which is really good. And as they come through, you note that that's what they are on the right-hand side. So based off of your examination findings and the blood results that you can see, what's the best treatment option for this patient? And I'll give you a couple of minutes, let's say 3 minutes, to have a read. Okay, so it's been a few minutes, and the correct answer is a course of IV coamoxiclav. So we'll go into why I've chosen that, or why the NICE guidelines say to prescribe that. The key learning point from this question was for a pneumonia, or community-acquired pneumonia. You have to calculate a CURB 65 score, which is on the left. And for each one of these criteria that is fulfilled, you score a point. So we'll go through it in this case. The man was confused. And if you remember his bloods, his urea was 7.2, so he scores another one for that. He had a high arrest rate of 33, and his blood pressure was on the low side at 85 systolic, and he was also 67. So he scores a full 5 out of 5 for in the CURB 65 score, which would classify him as having a severe pneumonia. And the treatment option for a severe pneumonia scoring a high CURB score is an IV infusion of coamoxiclav for 5 days. Yeah. Right, so we'll move on to the next question. A 55-year-old female is again being treated in the acute medicine unit for an infective exacerbation of COPD. When you look through her notes, you note that this is her third admission for an exacerbation in the past 6 months, and that every time that she's come in with a infective exacerbation, she's received a full course of treatment before being discharged for follow-up. Today on the ward round, you tell her how she tells you that she's noticed her clothes not fitting quite right, and that she feels a bit more fatigued towards the end of the day. As well as this, when you ask her to move from the bed to the chair, or just kind of move around, she says it's just a bit difficult to move from one place to another, particularly standing up. You do a quick examination, and you notice some bruising along her arms, as well as some prominent stretch marks on her tummy. Now, which one of the medications that she's currently on, or was previously on, is most likely to cause the symptoms? And again, I'll give you a couple of minutes just to have read and answer that. already. It's been a couple of minutes. So after having read of that and having reviewed her medications as listed above, the correct answer is prednisolone, and we'll go through why. So COPD, dealing with your acute exacerbations, you typically stratify them into your infective and non-infective exacerbations of COPD. And people with COPD are often prescribed the medications that are listed on the left. So they often have a SABA, which is required, prescribed as PRN or as required, and they're often on some combination of a LABA, a LAMA, and maybe an inhaled corticosteroid. However, during an acute exacerbation, we often prescribe them with a short course of oral steroid, as well as some antibiotic if it is an infective exacerbation. If we note back to the presentation, you note that she's had 3 admissions for an exacerbation of some type in the past 6 months. Therefore, in the past 6 months, she will have had 3 to 4 courses of oral steroids. This increases your risk of Cushing syndrome as you're getting that constant doses of steroid. And these are the typical signs and symptoms of Cushing syndrome. And I've highlighted them in the short list on the right-hand side. And again, I've tried to not make it too obvious in terms of what the signs and symptoms are. So proximal myopathy, our patient described difficulty transferring from the bed to the chair. So that involves your proximal muscles to try and get up and sit down. She's got easy bruising and thinning skin and on her arms, and central obesity with prominent abdominal stretch marks. Longer term, you're at an increased risk of fractures from osteoporosis, as well as developing glucose intolerance and diabetes-like symptoms. You can also get kind of facial changes and a buffalo hump as a sign that you can see. However, I've only seen that in one patient, and that was quite a long course of steroid that they were on. So 3 to 4 exacerbations wouldn't start to give you facial changes at this point. Hence, I've not included it in the question stem. I'd just like to highlight the GOLD report, which is essentially the gold standard of COPD treatment. I was always taught in medical school that it's a kind of increasing staircase, that you start with a SABA, then you add a LABA, then you add a LABA and a LAMA. However, quite embarrassingly, I was actually pointed to this report recently, which has now changed my practice in terms of how you stratify and what you prescribe people. So it's actually based off of these scores that you can calculate, and they're on MedCalc, as well as the number of exacerbations that you need, or that you need hospitalization for, in terms of what you actually prescribe. Essentially, it measures how breathless you are, and it's these COPD's kind of how much it affects your life against how many times you've had to go to hospital. So the more times you've had to go to hospital, and the more the COPD breathlessness affects your life, that affects what medications you're on. Just a small learning point for myself that I thought I'd share with you guys. I'm sure you already knew that, but it's just a good point for me. Does anybody have any questions? Right. Yes, thank you, Chan. Yeah. All right, next question. So, you're clocking in a patient admitted for an elective laparoscopic cholecystectomy for the next day. As part of your assessment with the anesthetics team, they perform an ABG, which is shown on the right. So, as the ABG machine is printing off on its little piece of paper, the anaesthetist asks you, what does it show? And I'll just give you a couple of minutes to read the question and look at the ABG results. Alrighty. So this ABG is showing respiratory acidosis with full metabolic compensation. Now I know that might be a bit confusing as the pH is normal, but I'll take you through my kind of heuristic on how I look at ABGs. So I look at the pH. So if it's high or low, that tells me if it's acidosis or alkalosis, and I'll just pull up the ABG results there. Next, I'll look at the CO2 or PCO2, and that tells me if it's a respiratory cause or a metabolic cause. So if it's the PCO2 is high, that tells me it's more likely to be respiratory, or if the CO2 is low or normal, then it's more likely to be metabolic. And after that, I tend to just look at the bicarbonate, which gives me whether there's been a metabolic compensation, essentially whether it's an acute thing or if it's a chronic thing. Now, looking at the pH, looking at the ABG, I can see that there's normal pH, which, okay, that looks good. However, I note that the PaCO2 and the PO2, the CO2 is high, above the reference range, and the O2 is a bit low. So that tells me that there's something a bit wrong, and the PCO2 tells me it's respiratory. The high HCO3 or bicarbonate with a high base excess tells me that the body is compensating for it. So there's a high level of bicarbonate ions that is compensating the acidosis or the respiratory acidosis that the high PCO2 would be causing. How can I tell that it's being compensated and that it's chronic or long-term? Well, bicarbonate production in the kidneys, it takes a long time. So if you're in acute respiratory acidosis, so for example, if we were suddenly on Mount Everest, your HCO3 would take a couple of hours to days to start to rise to compensate for the respiratory acidosis. Whereas in this ABG, I can see the HCO3 is rather high at 35, where the level I'd be happy for it to be at is 26 or up to 26 milliequivalents. I'm also looking at the base excess, which is raised at +4. And what that tells me as an F1 is the rate of that these ions are being used up. So +4 means that there's a high rate of production for the HCO3, which implies to me that the HCO3 ions are being used up by the respiratory acidosis that's ongoing. And so it's effectively this patient has been in some form of respiratory failure for a long time, such that the kidneys have actually had the time to compensate by producing the bicarbonate ion to try and normalize that pH. On the right-hand side, I thought I would go through the differences between type 1 and type 2 respiratory failure. So I'm quite a simple person. Type 1, there's only one thing wrong, so a low O2. And type 2, there are two things wrong, so a low O2 and the high CO2. I've also just mentioned quickly what your usual treatment modalities are. For type 1, we normally try and treat that with continuous positive airway pressure, CPAP, think of it as the big machine that locks on. And type 2, we like to treat that with BiPAP or bi-level to try and help the lungs ventilate that CO2 and O2 out. Going back to my previous slide, in terms of other good uses for ABGs and VBGs that you might encounter as an FY1, the ABG or VBG machines, when you run the bloods through, will give you rapid electrolyte results and the lactate. So oftentimes when a patient is acutely unwell and I'm suspecting something like hyperkalemia, or I'm suspecting that they're a bit septic, so I need a lactate to guide my management, I often do an ABG or a VBG if I'm already taking bloods, and I run it through the machine, and it gives me fairly accurate electrolyte and lactate results. However, just to be on the safe side and to make sure I've got the correct result, I always confirm it with the laboratory bloods, which can take a couple of hours. So, for example, if I've got a patient who I know is in renal failure and I'm suspecting that they've got ECG changes and I need to confirm a raised potassium, I'll do an ABG or a VBG and run it through the machine, as well as my Usenease potassium test. So that way I've got a quick test and one that backs me up in a couple of hours' time. Okay. All right, next question. So you've got an 8-year-old man presenting to A&E feeling really breathless whilst competing at a sports event. So when you look through his past medical history or GP records, and he's a known asthmatic, and recently he's been changed by his GP from salbutamol and his usual regime to PRN anti-inflammatory relievers. So I think it's a sulfonylureol and ICS alongside a new maintenance and reliever therapy. However, that doesn't really matter because right now he's acutely short of breath and is starting to get a bit panicky. The paramedics, when they bring him in, tell you that they've tried salbutamol both with the inhaler and the nebulizer. However, this has had not much of an effect. You've asked for a set of observations which are on the right. So the A&E registrar turns to you and asks you, right, you've seen the patient, how severe is his asthma attack? Again, I'll give you a couple of minutes to just read through and we'll go through it afterwards. Okay, so this patient, from the observations, is having a life-threatening asthma attack. So in terms of stratifying what asthma severity, you've got moderate, severe, and life-threatening. If you're seeing them in hospital, they're probably having a severe or life-threatening asthma attack. So I've focused on those three here. We'll start with the lesser of the two, so severe. And these are taken directly from the NICE guidelines. So this is what they will expect you to recognize and identify in the question stem. So if the patient is unable to complete their sentences, if they're hypoxic, if their respiratory rate is more than 25, and if they're a bit tachycardic at 110 beats a minute, and if their PEFR, or predicted expiratory forced rate, is 33 to 50% of their predicted value. So that if you remember from your placements, that's the one where you've got the tube and you ask them to blow out as hard as they can, best of 3. And then you plot it on a graph based on their age and weight, I believe. However, as I mentioned, this patient was having a life-threatening asthma attack, and the way I remember that is with the shock mnemonic. So they've have a S for silent chest on auscultation, H for hypotensive, PEFR of less than 1/3 for O. They're going to be cyanotic or with a saturation less than 92%, and K, just to fit with the mnemonic, they're confused with a K. I know it doesn't quite fit, but yeah. One other thing with life-threatening, and is that when you do it too, the PCO2 is likely to start to normalize. The patient will start to tire, and they will. So when somebody's having an asthma attack, their respiratory is going to be increased, which will be blowing off their CO2. However, when they tip into life-threatening asthma, and their respiratory muscles start to tire, and their respirate becomes less effective, or their respirations become less effective, the CO2 will go from low because they're blowing it off. It'll start to go back to normal because they're being less able to blow off any CO2 that they're producing. Just a handy thing, it often does come up where they give you an ABG instead of some observations. So in the context of an asthma attack, a normal PCO2 is still a bit worrying for me. So in terms of why do we care about this? As I've mentioned, it's quite common in A&E when you get to have observations and when you talk to a patient with asthma, people will ask you, okay, how severe is it? And that's because according to the NICE guidelines, which the MLA will test, the severity of the asthma attack will guide what you do. So moderate, if they've presented typically in GP or somebody's called 111, they'll ask them to try 10 puffs of their salbutamol inhaler, and if they've got an oral steroid, they'll try and manage it, not in hospital. All of these come with the caveat of if you try the treatment and it doesn't respond, or the patient's clinically getting worse, you transfer them to hospital. However, when severe and life-threatening, the treatment changes. So you go from inhaled or inhalers to nebulizers, nebulized salbutamol and ipratropium, with an emergency transfer to hospital. With life-threatening, I would be calling ITU pretty quickly to try and get to start the life-threatening asthma protocol that every trust should have, and that will include theophylline, aminophylline, and treatments like that, as well as identifying life-threatening asthma and getting ITU to come and review the patient quite soon will help in case they do need to go to the intensive care unit. There will be a bed ready for them. Right, does anybody have any questions? Yes. You could also have the wonder drug that is magnesium sulfate that will help with the bronchodilation. I absolutely love magnesium sulfate. It does so many good things. But in the context of asthma, we do give MagSulf. Yeah, thank you. Right, next question. So again, busy day in the ED. Another 18-year-old has presented following an altercation. On examination, he's got a stab wound to his right upper chest, about here, as well as some bruising to his abdomen and abrasions to his arms, and he's got some blood in his nose. On examination, he's breathless and he's a bit panicked, but he has just come from an altercation. When you go to see him, you note he's had a full A2E and some of these documented, which is on the right. So based on the presentation and the observations that you can see on the right-hand side, what's the best initial intervention in the A&E department. And again, I'll give you a couple of minutes for that. Alrighty, so if this patient comes to you with the history and examination findings, the best initial intervention, according to the NICE guidelines, is a needle decompression on the right-hand side, which is where the examination findings are, to the second intercostal space in the mid-clavicular line. And that's because this patient is presenting to you with a tension pneumothorax. If you were to do a chest X-ray, it would kind of look like this, but on the right-hand side. So you've got that. I've drawn a quick outline to where the lung parenchyma is, and all of that space above and below that isn't bounded by the red line is just air in the pleural space. So just quickly detailed the difference between the three types of pneumothorax that you can typically get asked about. So primary is just air in the pleural space that without any disease or pathology. So it tends to happen in young, fit people. You can have spontaneous pneumothoraces that are often asymptomatic, and people only come in when they start to feel a bit short of breath, and that's when they become a bit larger. Your secondary is, again, air in the pleural space with pre-existing disease, so things like asthma, COPD, or if you've got lung cancers, or if somebody stabs you, or if you come up with a hole in the pleural space and the air can come in there. A tension pneumothorax is then air in the pleural space with hemodynamic compromise, and that's essentially where you start to become unstable, so high heart rate, high respiration, low saturations, and a low blood pressure. Now, I was a bit mean in terms of putting a couple of options that are good interventions for a pneumothorax. However, if you note that the question stem asks for the best initial intervention, which in this case is the needle decompression. As I've noted here, it's a clinical diagnosis, so if the history and examinations findings fit and there's a hemodynamic compromise, you shouldn't waste time and order a chest X-ray or a CT scan. If the patient is acutely unwell and you think it's a pneumothorax, you should needle decompress or attempt a finger thoracostomy if you've been trained to do so. I note specifically within the BTS guidelines that if you've got a pneumothorax over 2 centimeters in size, so like this one, you can measure this in your PACS or your imaging viewer. You should really drain that and insert a chest drain for the kind of medium-term management of that pneumothorax. So in terms of where you can go quite safely, you've got your second intercostal space, mid-clavicular line, that people will tell you about in medical school. However, now we're also moving towards your third, fourth, and fifth intercostal space in the anterior mid-axillary line. This is in the area known as the triangle of safety, and it's just a bit of a larger space. There's also an alternative. If you've already tried the second intercostal space spot, you can try in the alternative region. Okay, moving on to the question number 6. So you've got a 65-year-old man presenting with GP complaining of non-refreshing sleep. So he's telling you that it's kind of gotten worse over the past year and is now disrupting his work as an office manager. He can't really concentrate, and he's having episodes where it feels like he's about to sleep during the day. In his social history, he's a smoker, and he drinks a bottle of wine every night with his dinner. His wife is also there, and she tells you that he's not very good to sleep next to, as he's a loud snorer and he keeps turning and tossing. Sometimes he sounds like he's choking, and he kind of splutters and then he goes back to sleep. She's really concerned about his sleep quality and whether he's safe to drive. So, given all of that information and the observations on the right, what's the next best step in his management? I'll give you a couple of minutes for that. Okay, so what this man should receive in terms of, according to the guidelines, is a trial of CPAP as well as lifestyle advice, because he's presenting with obstructive sleep apnea, which is defined as just a transient loss in muscle tone in the upper airway muscles during sleep, causing a transient or reversible airway obstruction. From the question stem, he's got a couple of the risk factors. So he's obese, he's got a large neck circumference, and he drinks a lot of alcohol, and he also smokes. So typically, when we see patients in the acute medical unit with obstructive sleep apnea symptoms, we send them for sleep studies. So that's an overnight pulse oximetry, or if it's really severe, we send them for polysomnography, which measures, which tells us how severe it is. You can also use the Epworth Sleepiness Index, which is a questionnaire that patients can use. And again, that essentially allows you to look at the NICE guidelines and calculate whether they've got mild OSA with symptoms that don't affect usual daytime activities, whether they do, or if it's severe OSA. So in this case, I've assessed him as having mild obstructive sleep apnea that is starting to affect his quality of life and his usual daytime activities. And as a result, my first line treatment would be to offer fixed level CPAP, or just a CPAP machine that he uses at night. And again, I would reassess that and offer him follow-up in a respiratory clinic as an outpatient. Okay. Does anybody have any questions? We'll move on. It's okay if there are. All right, question 7. So you've got a 65-year-old female presenting, who's a post-op hip replacement, presenting with new chest pain. During the consultation, she tells you that sometimes when she coughs up, she brings up phlegm with some streaks of blood. She also tells you that on her right-hand side, it tends to hurt more when she breathes in. So examination findings are on the right, and they're a bit small, but hopefully you can still read them, in terms of what's the most important diagnosis to exclude. And again, I'll give you a couple of minutes for that. And if anybody has any questions on this question or the previous one, just feel free to put it in the chat and we'll answer it. Yes, yeah, thank you, Paul, for putting that in the chat. I agree. So all of these are possible differentials for hemoptysis and a little bit of chest pain and new difficulty breathing. However, as you correctly pointed out, a pulmonary embolus of this size will probably kill you within a couple of hours, 2 minutes, depending on how large it is. So you need to exclude that and treat it. And how do we do that? So we'll just start off with why I put that in. So I was taught in A&E that chest pain with a new oxygen requirement and some shortness of breath, you must exclude pulmonary embolus. And the way you can do that is, if you look over to the right, with a 2-level Wells score to estimate the probability of PE or DVT. Now, you must note that there are different scores for PE and DVT, so you have to use the correct one depending on the signs and symptoms. So this is the one for PE because it's the one that is most appropriate for this presentation. After calculating your Wells score, again, I would highly promote having MD Calc, not sponsored. It's just a good app to have on your phone. Once you've calculated that, if the Wells score is over 4, a pure pulmonary embolus is highly likely. So you should request an urgent CTPA and start treatment. And your treatment options for a pulmonary embolus range from DOACs to treatment dose low molecular weight heparin. I've not gone into which one you would choose in this question, as the learning point I was trying to get at is recognition of a PE and what you would do next. You would choose a DOAC or a treatment dose low molecular weight heparin, depending on whether you've got surgery coming up or if you've got previous cancer, or essentially the fitness of your patient to undergo the treatment. As a final point, you've got a difference between your provoked and unprovoked PEs. And that really informs your treatment duration. So if there was a provoking factor, I believe the treatment that you discharge them on to prevent recurrence of a PE is shorter at 3 months. And if it was unprovoked or there were no risk factors, i.e. it just happened out of the blue, you'll send them on treatment for 6 months. Please correct me if I'm wrong. That's how what I've always prescribed. All right, next question. So you've got a patient who's 37 and she's got increasing shortness of breath, and they've progressed over the past month. She's also got left-sided chest pain when breathing in. On examination, you've got reduced breath sounds on the left-hand side below the fifth intercostal space, and the stony dull percussion sound over the same area. You do a chest x-ray and you see a left-sided pleural effusion, and you're very brave, and your registrars are right next to you, and you do a pleural tap. You send the pleural tap off for cystoscopy and microscopy, and again, they're very rapid, and they give you just a blurt of information. It's on the right and also in the text. So, if your registrar asked you, is this a transudative effusion? And if so, why is it a transudative effusion? Out of the following options, which one makes it or leans you more towards a transudative pleural effusion? Alrighty. So, based off that blurt of information, I know that was rather a lot. So, the protein being 20 grams per litre or less than 25 tells you that it's more likely to be a transudative pleural effusion. So, the definition of this is a fluid accumulation in the pleural cavity. And it's often diagnosed with a chest X-ray, which will give you a nice fluid level appearance of varying sizes. Sometimes it can be quite subtle, right at the bases. Sometimes it can be very obvious. This case is taken from one that I saw on an on-call night, and I was that fortunate F1, depending on how you look at it, to try and do a chest drain at 3 in the morning. And these came back, and it was a transudative because of a low protein. So transudative, again, I'm a simple F1. Transudative sounds a bit like transparent. And transparent, you can see through it. So the protein level will be low. So less than 25 grams per litre is how I remember it. An exudative will have more protein in it, so it'll have the higher level. However, if the protein level is between 25 and 35 grams per litre, your registrar or you, if you're feeling smart, which you probably are, will use Light's criteria. And if any of these are matched, then you by definition have got an exudative pleural effusion. And essentially, why do we care about a transudative versus exudative? It tells us what the cause is, and so we can start treating it appropriately. Because as much as we want to just keep draining the fluid from the lungs, we have to stop the fluid being produced in the first place, which is, I know it sounds pretty basic, but that was a key learning point for me in my first week of F1. I can't just keep draining the fluid. But anyway, last couple of questions then. Question 9. An 18-year-old man presented at acute medical unit with fever, cough, with new streaks of blood, and some neck lumps to the front of his neck. When you ask him to take a history, he's very polite, and he tells you that he's moved to the UK from Nepal from military training. And he also tells you, just as you're leaving, by the way, he's having a bit of difficulty sleeping, and he often wakes up drenched in sweat, and that's not nice for him. It's just a bit uncomfortable. He's also struggling to complete his military basic training, and he's losing weight despite trying to eat more. We give him the correct treatment. However, when you come to follow him up in a couple of weeks' time, he comes back and he says, right, I'm having real difficulty looking at colours now. So I've noticed it when I'm on a range day, and I'm trying to look to see if there's a red safety flag versus kind of whether I can shoot or not. Now, you look at his medications and you see that he's received all of these for all of these medications. Now, which of these ones is most likely to have caused the side effects or the symptoms that he's now describing? I'll give you a minute or two for that. This was actually based on a patient that I saw in my wee little hospital. So this thing really did happen to me, but I've turned it into an MLA style question. Alrighty, so after being prescribed the famous RIPE therapy for what sounds to be tuberculosis, it'll be the ethambutol that's causing the transient optic neuritis with the red-green color differentiation. So TB is a highly infectious, reportable respiratory disease caused by Mycobacterium tuberculosis. It can cause a wide range of physical manifestations, typically in the chest. However, it can spread to organs such as your spine for Pott's disease, your GI tract, and your reproductive organs if left untreated. When you suspect acute tuberculosis, you hit them hard with RIPE therapy or rifampin, isoniazid, pyrimidine. The one that starts with P. I'm not very good at pronouncing these words, and ethambutol. However, each one of these medications, whilst they're really good at treating TB, can cause specific side effects that we need to know about. So rifampin can cause red discoloration of your tears, sweat, and bodily fluids. And it's quite distressing if you can imagine suddenly you're peeing red, or your tears turned red. Isoniazid can cause your B6 deficiency related peripheral neuropathy, so you often have to supplement that with some B6. It can also cause drug-induced lupus, and it's also a CYP450 inhibitor. So if you're on things like warfarin or other medications that rely on your CYP450, you get drug interactions. Pyrazinamide causes hepatotoxicity and gout-like symptoms caused by hyperuricemia. So you can prophylactically treat with that with some anti-gout medications alongside. And lastly, the one that's causing the trouble in this case, ethambutol, causing red-green color blindness, which requires baseline and follow-up vision tests. I tried to hint that this was a man who's recently moved to the UK, so just to really drive home that tuberculosis. But yes, I saw one of my soldiers coming in with this presentation, and I just thought it'd be a nice link into TB. Right, final question. Question 10. A 36-year-old man presents to his GP with recurrent chest infections. He's febrile and has a productive cough. In his past medical history, you note that he's got diabetes, and he's been seen a few times by general surgery for gallstones. When you look at him, he's slim in build, shorter than average, with noticeable finger clubbing, and his observations are on the right. Given the likely diagnosis, what's the most likely causative organism, or the one that's most likely to cause his presentation? And again, I'll give you a couple of minutes for that. Okay, so this man likely has cystic fibrosis, and I couldn't exactly give it away in the past medical history, but in cystic fibrosis, your most likely causative organism for pneumonia is Pseudomonas aeruginosa, and we'll go through why. So cystic fibrosis, as we know, is an error in the CFTR gene, so you get a defect in the transport of your chloride ions, and so you're unable to produce normal sputum, and that causes thick sputum as well as failure to produce. You essentially get thickened secretions in your respiratory tract, in your GI tract, which can lead to things like pancreatitis, recurrent gallstones, as well as reproductive difficulties, and which I was trying to hint at. All of these in this past medical history. It's known to be an autosomal recessive in inheritance, and one of the key facts with cystic fibrosis is because of these thickened secretions, you get colonization of the secretions of Pseudomonas, and that it causes the greatest burden in mortality and morbidity. And so you often start, if a patient comes in with a pneumonia and you can see they've got cystic fibrosis, you often just start them on the treatment for Pseudomonas, as well as taking a sputum sample for MCNS. The current theory is that the Pseudomonas forms a biofilm within the sputum itself, which can resist the recurrent antibiotic therapies. So it's quite a high yield fact to know that if somebody has a pneumonia and they've got cystic fibrosis, it's more than likely going to be Pseudomonas in nature. Alrighty, that's it. That's our 10 questions. Does anybody have any questions or any queries? We'll do our best to answer. Thank you.
Hi guys. So for those of you who weren't there at the start, my name's Shantae. I'm one of the F1s around Greater Manchester this year. Just a few things to sort of highlight or sort of point you in the direction to. So like Erin mentioned earlier on, there's been the recent change of the NICE guidelines in regards to asthma. So definitely go and have a check. Definitely go and check those out. Especially because it's a lot simplified now and it's sort of better and more beneficial for the patients, but just don't fall into the trap of sort of falling back onto the old guidelines. And then also as well, just point you in the direction to the change in the pneumothorax guidelines as well. So sort of Erin mentioned it as well, but there are some high risk characteristics that you'll need to be aware of, such as the age, if there's a bilateral pneumothoraces, if the patient is significantly hypoxic, that could then sort of point towards an indication of a chest strain as opposed to sort of needle decompression. So that's just to be aware of as well. But yeah, if anyone's got any questions, either pop it in the chat or give us a shout out as well.
And in terms of the slides and recording, I believe we'll be uploading these onto Medal, and you should get a copy emailed to you if you fill in the feedback form, please. Thank you so much. I feel like as a med student, I got so used to filling in feedback forms that even now outside of medicine, I'm like, do you want feedback? And people are like, oh my god, yes. Like yeah, I had an appointment for just something outside of medicine, and at the end I was like, do you have like a feedback form that you want me to fill out? And the guy just looked at me like, what? I was like, oh well, just when in my work, everything gets a feedback form. So, I don't know. Is that sad? That's probably sad.
There was also another point that I wanted to mention as well, but I thought it'd just be easier to sort of say it rather than type it out in the chat. I don't want to sort of complicate things too much. But for anyone who's interested, just in terms of extra reading, it probably wouldn't come up in sort of that much detail sort of on the MLA, but it is in regards to acute hypercapnic respiratory failure and when to use BiPAP and NIV. There are sort of like 4 principles or 4 conditions that you would really consider patients to sort of start in NIV. That's, patients with like known COPD, neuromuscular diseases, chest wall deformities, like OHS or OSA. And I can't remember the other one, but then the patient would also have to be hypercapnic, so PO2 above 6 and PO2 less than 8 as well. But it's just to be aware of. So basically, if the patient is acidotic and they have sort of those 4 underlying conditions, when do you start an IV? So it's sort of on the BTS guidelines of the British Thoracic Society. So just if anyone wants to sort of take up a bit of reading and sort of read more into it and gain a deeper understanding of NIV. Yeah, of course. Let me see. I think I've got it up here. The actual guidelines I can probably post up in the chat. Where's it gone? So it's acute hypercapnic type 2 respiratory failure. Basically, like Erin was saying earlier on with one of the questions, you have a patient who is sort of known COPD, and there might be a proven retainer, so they constantly have sort of high CO2, and high bicarb, but they've been able to compensate it. But then those patients you see, especially when they come in with sort of acute exacerbations of their COPD, there might be acidotic on that admission. So there are ways to medically manage acidotic patients, but sometimes obviously that doesn't work. So then that's when you look to start an IV with those patients. But yeah, if you just have a Google, it should come up in the British Thoracic Society, and as well, and NICE as well.
Our dean was a respiratory consultant who was a member of the BTS. So our respiratory block was just her going, "You will learn the BTS guidelines, not the NICE guidelines, the BTS guidelines." So when I turned up on acute meds on AMU, going, "Well, if it's more than 2 centimeters," and the registrar was like, "Why do you know that specific thing?" It's like, "Well, my dean specifically told us." So, yeah, that was a very nerdy moment. But yeah. Right,
Yeah,
it is 1:15. Thank you so much for your time. We'll see you next week. For another session. Thank you. Please fill in the feedback, and we'll see you next Thursday. All right, bye.